we figured out for ourselves, or what was the one that you had us?
It was on the homework.
Which one was that?
It was on the homework cardiac index.
Oh, the
For
cardiac.
a
So,
term.
so it's specific to our height and weight, basically. It's basically our body
Yeah.
surface index, our mass, body mass index.
What was the one that you had us figure out in class? Do you know? Does anybody remember?
That's been way too long ago. I
Okay.
can't remember that far back.
It's okay. I was trying to figure it out because we were talking about it. Kate and I were talking about it the other day. But
Okay.
can you figure out the
You-
cardiac index?
You
Just-
can on in the back of the text. You can look at. There's essentially a graph. I can show you. Nomograms, transport studies, cardio. So here we go. Hemodynamics on 643. So if you know what your stroke volume is, or your cardiac, let's see,
So what are you now?
643. So you've got body surface area on the previous page. Anyway, if you know what your cardiac output is, you can calculate what your, and basically you just put a line on this ruler, a ruler on these numbers to calculate what the other measurement should be. But just in general though, a cardiac output is around 5 liters per minute. A cardiac index is determined by your size, your height and weight, okay? So a person that has cardiac output of 5 liters, we can compare that across the board, but it's going to be different depending upon if you use, remember Armando and Megan maybe, different body size. They'll have different cardiac outputs, but they'll have roughly the same cardiac index. So cardiac index takes into account body surface area. Okay. So cardiac index, the average is around 2.5 liters per millimeter squared. So a 5 liter cardiac output is equal to a 2.5 liter cardiac index, but we're comparing in outputs apples to oranges. We're comparing apples to apples with cardiac index because it takes into account a person's size. Okay, so in this chapter they talk about index, stroke volume index, and all they're doing is they're taking the stroke volume divided by body surface area. So that allows us to compare apples to apples if you look at index. Okay, now in the hospital and clinical situations, they'll interchange output and index. We just know that if they use an output, that it's an average roundabout way to describe it. If they say index, then it's compared to body surface size. Okay, so if they use cardiac output, we say, oh, okay, we're just making a generalized sense of how much volume is circulating around. If they use cardiac index, we say we understand that it's in relation to their body surface area, and it's a much more precise measurement compared to how big they are. Okay? So output versus index. Same thing here. Stroke volume is the amount without taking into account a person's size. So a stroke volume is simply the amount per ejected per contraction. A stroke volume index is the amount per contraction based on body surface area. Make sense? So we're being more specific, more precise in that measurement. Cardiac index, just like we said, cardiac output is the average amount. The index is taking into account body surface size, and so it's more specific and more precise measurement about cardiac output. And remember, index has 2.5 to 4.2 liters per minute per meter squared. So an index, anytime they use the term index, it's taking into account a person's size. If they use output, then it's just an average way, or stroke volume, or cardiac output. It's just the amount. So then they go so far as to give you information about right ventricular stroke work index and left ventricular stroke work index. I don't want you to remember anything other than the definition. Okay? Just be able to define what right and left ventricular stroke work index. It's the amount ejected per contraction of the right or left ventricle, taking into account body surface area. That's it. They give you a calculation for that. Notice I'm glossing right past the calculation. We just want to remember what that is. Seldom do I see it in use or practice other than to make sense of resistance at the bedside. So if stroke work index goes up, it just means that the ventricle has to pump harder against more resistance, right? So that's the only context that we use, right and left ventricular stroke work index. Cardiac output, cardiac index, stroke volume index, and factors that increase and decrease vascular resistance. So vascular resistance is vascular resistance is systemic blood pressure. Pulmonary resistance is pulmonary blood pressure. So the 25/12 is reflected in pulmonary vascular resistance. The 120/80 is reflected in systemic vascular resistance. Okay. Factors that increase and decrease resistance. Pay attention to those tables. And I just wanted to, if just for time's sake, we can go over the clinical application and show you how we use hemodynamics in the care of patients. So if you'll permit me, I'm just going to kind of read through the clinical application case. So in the first one, a 71-year-old woman, sudden chest pain, reported sudden chest pain to her husband while working in the garden. Moments later, she collapsed. Her husband called 911. Upon arrival, paramedics charted these vital signs. Blood pressure, 64/35. Okay, is that a good blood pressure? Not so good. Remember, you have to have a blood pressure of 60 to perfuse the kidneys. So we're just barely holding on at a blood pressure of 64/35. Heart rate was 32. Is that good?
No.
Respiratory rate, 4 breaths per minute. Yikes, we're in big trouble. This was Jimmy's patient yesterday. So respirations were shallow. CPR was initiated. The patient was transferred to the hospital en route. IV line was inserted. A bolus of epinephrine was administered. The emergency department patient's vital signs were 78/50. That's a little better. Heart rate was 42. Spontaneous respiratory rate was 16. Dopamine was administered. And the heart rate increased to 60. Despite improved heart rate, however, the patient's blood pressure remained low. Okay, so you would think that if we raise the heart rate, that it would raise the blood pressure. Let's see. And the patient's skin was cold and clammy. After administration of 3 liters of oxygen, patient's ABG values, pH was 7.54, CO2 25, bicarb 22, and a PaO2 of 62. They always, in any text you read, they're going to assume a normal PO2 of 80 to 100. That's sea level, right? So 62 is dramatically low. EKG showed complete heart block. Patient was immediately transferred to the coronary care unit. Bedside transvenous cardiac pacing wire placed under fluoroscopy. Ventricles were paced at a rate of 80. Pulmonary catheter was inserted. A hemodynamic profile was obtained. After evaluating the first profile, the physician made a diagnosis of cardiogenic shock. I have to tell you the statistics of cardiogenic shock. Of the patients that suffer in MI, 80% of them go into cardiogenic shock. 15% of the 80 will die because of cardiogenic shock. Let's see. So he's been diagnosed with cardiogenic shock. 1 hour later, patient was breathing 50% oxygen, ABGs 743, CO2 33, bicarb 24, PO2 108. Those are probably ideal ABGs. Urine output was 35 milliliters per hour. Why the hell does urine output have any influence? Yes, exactly. It's extraordinarily important. So even though we're dealing with the heart and the lungs, information about renal failure, renal function, and urine output, that's a very good sign in the evaluation and assessment of your patient. It means that the kidneys are being perfused. If you're producing 105 milliliters of fluid, that's a very good sign. So even though we may not think or pay much attention to urine output, it still is an important piece of information. Urine output's 105 milliliters, 108. Let's see, 35 milliliters per hour. Patient's skin was warm and dry, respiratory rate was 12. Second time patient's hemodynamic profile was obtained. So here's, in the next column, you've got a blood pressure of 85/55, now it's 91/55. Heart rate's 80 both times. CVP in both cases were 9. So it's a little bit higher than normal, probably because they got a fluid bolus. Okay. Right atrial pressure was 10 both times. The pulmonary artery pressure was 18 the first time and 16 the second time. Pulmonary capillary wedge was 21 the first time and 13 the second time. So what it says is that the right side of the heart's okay, now the wedge here is reduced. What's the reason for that lower wedge pressure? Case illustrates the adverse ripple effects of elevated afterload on a patient's hemodynamic parameters. A very high systemic vascular resistance and pulmonary capillary wedge pressure and low chloride in hemodynamic profile 1 showed that the patient's afterload was elevated. Although dopamine is good, as a good agent to increase the patient's cardiac index, in larger doses it causes systemic vascular resistance to increase. So what happened is that the lungs became very stiff and the vascular system was harder to move blood through the pulmonary system. So that's why the pulmonary capillary wedge pressure went down as opposed to going up, is because resistance all of a sudden increased. Let's see, because the SVR was already high, nitroprusside, a vasodilator, was used to reduce the patient's afterload. After administration of nitroprusside, the patient's blood pressure essentially remained the same in the second hemodynamic profile, while their wedge, cardiac index, SVR, and urine output all improved significantly. In short, the patient's SVR decreased in response to nitroprusside. Left ventricular afterload was decreased. This action in turn allowed blood to be more readily ejected from the left ventricle. A cardiac pacemaker was permanently implanted, and the patient progressively improved and discharged after day 7. So you can see how they use medications and fluid to raise or make sense of the resistance so that they can treat a patient effectively. And that hemodynamic measurement would have been particularly important. I mean, on the outside, if you would have given dopamine and without the pulmonary artery catheter, you wouldn't have been able to recognize that the capillary wedge pressure was elevated and treat them appropriately by giving nipride. So that was instrumental in reducing the resistance and then perfusing the lungs to help her to, in this case, she survived and was discharged and went home. So pretty amazing how hemodynamics can help us be the clue to what to do to help to improve how we circulate this blood through the systemic and pulmonary circulatory system. And that's what this does, is it gives us information so we can make clinical decisions at the bedside. More information is better. And you'll find that in clinical practice, the more information we have, the better decisions we make. And without these catheters, now it's getting to the point where these catheters are very expensive. They're very invasive. There are complications associated with their use. And so many hospitals, even critical care hospitals, are thinking twice about using pulmonary catheters, pulmonary artery catheters. The information is invaluable, no doubt, and the information is objective, but the information can be obtained through non-invasive means if you know what you're doing. You can do assessments, like capillary refill. You can do simple assessments that tell you about vascular resistance. You can pay attention to urine output and know what's happening with vascular resistance. We don't need a $1,000 catheter to tell us what the wedge is if you know what the associated, what the capillary refill is and what the urine output is, and you can associate that into a body of knowledge that allows you to make clinical decisions based on non-invasive assessments versus a catheter that they thread through your heart. See what I mean? We have to be smarter in the assessments that we use, and we have to be knowledgeable about what other things can give us the same kind of information than floating a $1,000 catheter into their heart. And that's hard to do. It's hard to have that information readily available that we can be knowledgeable about and use at our discretion. But that's what medicine is asking us to do now. We have to be smarter in the assessments that we do and be able to connect them with cardiovascular and renal information to let us know about resistance and circulating blood flow and hemodynamics that currently, when these things first came out, everybody got a Swan-Ganz catheter. And we measured them, we measured the numbers all the time. But anymore, they're being careful about resources and how much they expose patients to and how expensive that care is. We can do it, there's no doubt. But physicians and hospital units and corporations, because hospitals are businesses, right? Corporations are paying attention to costs, and costs of a catheter like this is very expensive. And so we have to realize that there are other ways to do these same kinds of assessments without spending $1,000 on a piece of equipment and going to the expense. You know, if you're, how old, 84 years old, and you have a dissecting aortic aneurysm, they probably didn't put a pulmonary artery catheter in. You know, we probably have to think twice about long-term survivability and quality of life issues. 20 years ago, we didn't consider that, Jimmy. We didn't. That didn't enter into the equation because we're healthcare practitioners. We save everyone, right? But now, in medicine, costs and efficiency and quality of life have bigger portions of the conversation, and now we have to make decisions about when we intervene and at what expense. Okay. Anyway, so I encourage you just to take a look at the second clinical application. It gives you 3 different profiles, and you can make sense of that. In this case, they're using PEEP. Now, one of the things that we do in hospital practice is, you notice in the first one, they did a blood gas to assess ventilation. What was the CO2? What was the PO2? You have to realize that in the PA distal line, and this one right here, so this line is marked PA distal. That means that there's an opening right here at the tip of the catheter. We're drawing blood back into the tip of that catheter. One of the things we can do then is put that drop of blood into a blood gas machine. And we know for assessment purposes that if we draw blood gas, so in the artery, let's look at this one right here. So in the artery, the PO2, well, let's send it out this way. So once oxygen is dissolved across the alveolar capillary membrane, and we push a PO2, let's say, at sea level of 80. So our partial pressure here is 80. It dissolves across the alveolar capillary membrane as 80. So this is being pumped out by the left ventricle. Left ventricle. That goes out through the pulmonic, through the aortic valve, and now it's going through the arteries. We take a little bit of blood out from the radial artery and draw blood gas, and we notice that our PaO2 is 80. Well, that gets out through all of the circulation, and it comes back to the left side. That same, what started out as 80, it started out at a particular blood pressure, but then along the way, the partial pressure of oxygen was delivered to certain tissues in the peripheral circulation. So this is millimeters of mercury, this is blood pressure. But also, if our PaO2 in the artery, PaO2 of 80, it gets down here, and now the PaO2 is 70, and now it's 60, and now it's 50, and up here it ends up somewhere around 40 millimeters of mercury. Because just like pressure, we lose PO2, the capillaries are extracting oxygen from it. So the PO2 comes up here at 40, it gets into the right atrium, right ventricle, and then we pull it out of the catheter. So one really strong measurement that we can get through a pulmonary artery catheter is we measure what the PVO2 is. So in the venous system, we've pulled oxygen out. It left the left side of the heart at 80. It came back the right side of the heart with a partial pressure of 40. So it lost about half of its partial pressure as it went out to the tissues. The tissues combined it with sugar and oxygen and made ATP for muscular energy, right? So a powerful piece of this Swan-Ganz catheter is that we can draw something called mixed venous blood gases, or mixed venous. So we can do a pH, we can do a PVO2, PVCO2. It'll give us a bicarb. It'll give us a content, CVO2. It'll give us a hemoglobin. It'll give us a saturation, SVO2. It'll give us CO hemoglobin. It'll give us a net hemoglobin. It'll give us a base excess. So these are essentially all the numbers in an ABG. But the point is that if we can draw it from the radial artery, what's gone out from the left side of the heart, what is being delivered to the tissues, and if we can compare that to what comes back, how powerful is that to know what the tissues extracted? So on an arterial blood gas, let me just give you an example. So an arterial blood gas, 7.45, PVO2 is 80. A little bit. PVCO2 is 46. Bicarb 22, CVO2 20, hemoglobin 15 grams, SVO2 95, carboxyhemoglobin 0.1, net hemoglobin 0.2, base excess 1.1. So in a mixed venous blood gas, 7.40. PVO2 is, like we said, 40. CO2 is 40 in an arterial blood gas. Let's see, actually let's switch those two. 46 this way and 40 here. Bicarb should be about the same. CVO2 15 grams, hemoglobin 15, SVO2 60, carboxyhemoglobin, net hemoglobin, base excess. So in the end, I'm just given numbers, right? I've got an arterial blood gas and I've got a mixed venous blood gas. In the end, I'm just given numbers and I have to interpret the results, okay? Well, the thing that we focus on the most is the amount of oxygen, the content, the saturation, essentially, Lindsay, oxygen transport that we'll talk about next time. But it helps us to validate what we think's going on with what's happening in the lungs and gaseous transport and what the tissues are getting. So I'm comparing what I've sent out to the body for oxygenation and ventilation, and I'm comparing that with what I got back from the pulmonary artery in a mixed venous Swan-Ganz catheter, that I can measure these numbers again and find out what the tissues extracted, okay? So it may not look like much, but we often compare what we've sent out to the body and what comes back to the heart so that we can get an idea of what was extracted, what was taken out, okay? And in the next chapter, we'll talk about how we make sense of that, okay? But we do it with a Swan-Ganz catheter in the blood from an artery and the blood from a pulmonary artery catheter in the mixed venous system. Because it gives us relevance to how well your body functions in extracting oxygen and using oxygen for cellular metabolism, basically. Okay? So I think I'll stop with that as far as, definitions, yes, cardiac output, cardiac index, stroke work index of the right and left ventricle, stroke volume index, what they mean. Just focus on definitions more than anything. It's a fairly simple chapter, other than making sense of the numbers and where that catheter is in the CVP, the RA, RV, PAP, and PCWP. So know what those pressures are, because it'll become next to, we'll recognize the importance of those as you see them in clinical practice.